Hi, this is Brian Kim. I'm going to share with you my first iStent Inject W case. If you want to see kind of the step-by-step approach and thought process I had towards this device, I actually posted a video on the Simulize Model Eye and kind of the things that I learned and the step-by-step approach that I had with that first Model Eye case. And so I'm actually going to show you kind of the ins and outs and the challenges that a real eye had versus a Simuli Model Eye and the things that I learned on this very first case. After I've turned the patient's head away from me and I've positioned the eye appropriately, I'm injecting some cohesive viscoelastic to fill the anterior chamber as well as into the nasal angle. And then I'm using the BSS cannula to sweep the excess OVD onto the cornea. So this is the iStent device. That's the sleeve. You saw that I extended the trocar momentarily, but then I put it right back in. So the sleeve is protecting the trocar. The trocar is not exposed at this point. Only the sleeve is. And you can see I put the gonio lens on after I made sure that the sleeve was in the eye. And so I'm pressing down the teal button and I'm pulling it back to retract the sleeve, and now it's exposing the trocar. You can see the tube as well as the window through the tube. You want to rotate the tube in such a way that the window is exposed and I can see the tip of the trocar. When I place the trocar into the middle part of the trabecular meshwork, you want to dimple in to create a little bit of force. You want to make sure that the device end is in the neutral position, that the trocar is central and not being distorted towards the edge of the tube. And then you press down on the black button and it deploys the device. You saw that I did that and it happened so quickly with hemorrhage coming out. So it's very difficult to really know if I got it in place or not. And so that's the first thing I've learned with this case is, you fired the device and then suddenly there's all this blood. And so not quite as elegant as a Simuli eye. And so now I'm going to inject some OVD to clear out the blood and see if I can improve my view. So I'm pushing the OVD out, and lo and behold, the iStent is in correct position. And so I'm really ecstatic about that. Thankfully, my very first one, I didn't have any major issues. I'm pushing more OVD to fill the anterior chamber and to clear out the blood. And now I'm thinking about attacking the other site, which is going to be on the right side, to deploy this second iStent. So you can see here with the gonio lens in place, I'm rotating my chair, I'm turning it towards the left side, and I'm rotating my microscope, turning it clockwise so that it's more facing towards the right. The gonio lens is in place. I have the device in my hand again. The sleeve is forward, protecting the trocar. The trocar is not exposed. I'm going in through the incision. And then, as you notice here, my view is not as good. And I'm going to, again, retract the sleeve. I'm pushing the teal button down and I pull it back to expose the trocar as well as the tube. And I'm trying to determine if I have a good view of TM. And so what I'm seeing here is there's quite a bit of blurriness to my view, and I can see that the TM is obstructed by the iris, and I can see that the chamber is shallowing. So the first problem is, number one, the OVD has mixed with blood and that spilled out from inside the anterior chamber, especially when I pushed all that OVD out. All that OVD that was mixed with blood actually went up and in between the cornea and the gonio lens, and it obscured my view. And the second problem was the anterior chamber began to collapse and the peripheral iris was pushed up towards the angle structures and obscured my view. And the clue was the IOL optic actually prolapsed out of the bag. So I decided to push the teal button down and push the sleeve forward, covering the trocar and the stent, take the device out of the eye, and reassess how I can improve my view and also improve my access to the trabecular meshwork. So the solution was to come out, inject more cohesive OVD to fill the angle in the anterior chamber. Number two, place dispersive OVD at the incision to reduce OVD egress from the wound, and then placing new OVD on the cornea to displace the OVD that was mixed with the blood. So I'm going in with the cohesive viscoelastic cannula. As I'm going in, look what happens. I actually pushed on the lens itself. So the IOL is so anterior, it was actually against my incision when I was pushing it. So that was really not a very good chamber stability to do the iStent. And so I had to put a lot more viscoelastic, and now I'm putting some dispersive viscoelastic at the opening of the incision now. Hopefully that will tamponade any more OVD, and then I'm putting new OVD on the cornea. Hopefully it'll give me a clearer view and remove some of that OVD that was mixed with the blood. So now I have the device. I'm going in with the sleeve in place. My gonial lens is in place. I push the teal button down and pull the sleeve back. Now I can see the trocar and the tube in place. I'm going to place the trocar into trabecular meshwork, making sure I'm not causing any torsion or stress on the trocar, making sure it's neutral, and then I press the black button and deploy the iStent. Again, this same situation, as soon as I deploy, blood is just covering all over the angle, so I go back in with a cohesive viscoelastic cannula, and again, thankfully, the iStent is in good position. So I'm skipping forward now. I remove the viscoelastic from within the bag and now into the anterior chamber. Switching to visco mode, removing all the viscoelastic. And this is what I wanted you to see. You can see the blanching of the vessels nasally. And that's a pretty wide area where it's blanching. And so this tells me that the stent is functioning, that the BSS is flowing through the collector channels, and that's causing that blanching because the BSS is going through those channels. So now I'm going to hydrate my incisions, and that's the end of the case. So again, on this very first iStent case, this patient had a very shallow chamber. Iris was coming forward. Thankfully, that first case, I was able to deploy the stent pretty straightforwardly, making sure that the trocar goes in to TM, in the middle of TM, making sure that the trocar, once it's engaged, that the tube, I'm not moving the tube side to side or up or down, which will cause the trocar to not be central. If the trocar is not centered and in the neutral position, it will obstruct the ability of the iStent to go down the shaft of the trocar and embed into the TM and Schlemm's canal. Blood came forward. I had to put OVD to improve my view. When I switched to the other side, the lens was coming forward, the iris was pushing upward. I had a very poor view of the angle in TM. So when I came out, I was able to push more OVD, cohesive into the angle, and dispersive viscoelastic at the wound. I tried to remove some of that OVD that was mixed with blood that was coating the cornea. I still didn't think the view was great, but I was fortunate that I was able to deploy and actually place that second stent. Next time I would remove and flush the corneal surface more aggressively to remove all of that OVD and start all over, because that OVD that's mixed with blood really can affect your ability to see. And with a procedure like this, you really don't want to take that chance. So those are my learning points on my very first iStent inject W case. And I hope this was helpful to you. And I thank you for your attention.